Good afternoon, all. So, can we start now? Anusha ma'am, am I audible? Okay.
Yes,
So, first of all, I would like to welcome you all for the session, and we have our faculty Sachin sir is here, and I'm handing over to Anusha ma'am to introduce our faculty. Ma'am, over to you.
just a minute. Hi everyone, good afternoon. This is Anusha. I'm the facilitator for today's session. Uh, Today our topic is communicating bad news and collusion. Today our speaker, Mr. Sachin. Sachin is currently working as a nursing faculty at AIMS, Rishikesh. He has more than 11 years of experience in as a tutor, clinical instructor, ICU nurse, infection control nurse, and research nurse. He has published and presented over 15 research papers in national and international journals as a reviewer and editor, editorial board member. He has been actively involved in palliative care for last 6 years, and he has completed specialized training such as CCEPC, virtual palliative care training, and fellowship in palliative care. He is a mentor and faculty resource person for palliative care training, guiding international fellowship batches, and he is a life member of professional organizations like IAHPC and TNA Global Health Network and Asia Pacific Hospice Palliative Care Network. Welcome, sir. Welcome for this session. Thank you. Sachinji, are you here?
No, ma'am. Sir is facing some issues. We can wait for 2 minutes.
Dear participants, today we have class regarding communicating bad news. So where we can heard about the bad news? Can anyone say? What is meant by bad news in clinical settings?
Death of a person?
After diagnosis procedure. So what is the bad news in that?
Severe illness that we can't cure?
Sorry?
Serious illness that we can't treat?
Yes. In chronic disease, life-threatening conditions. So we have to communicate bad news. We are breaking the bad news for family members, right? So most of the palliative care centers and hospice centers, where we are using this word breaking bad news. In previous class, we heard about the
Hello, ma'am. Good afternoon.
communication.
Sorry, I'm a little bit late.
You can put it in chat box otherwise.
Yes, ma'am.
What is collusion?
Sorry for technical interruption. Am I audible now?
Yes, sir.
Okay, thank you. I'm sharing the screen. Okay, so we're talking about the bad news, how healthcare professionals break the bad news with the patient and family, and the situation sometimes the patient's family don't want to disclose it with the patient. So what are the effective strategies? What are the communication strategies we can use to effectively break bad news? So we are going to discuss in today's session. So at the end of the session, you are able to understand what is how it is important to communicate the bad news. What are the effective principles? What are the principles effectively we can apply whenever we break bad news? And at the end, you will be able to identify what is the collusion. And the most important thing, what are the challenges by the family and caregivers? And at the end, what are the nurses' role? What are our role to break bad news effectively with the patients and without affecting the emotional distress to the patient and family? So here is the scenario I have mentioned here. Mrs. Mehra, a 58-year-old woman, has recently been diagnosed with the advanced ovarian cancer. She is admitted to the palliative care unit with progressive symptom. Her husband and two adult children are her primary caregivers. In this situation, the medical team review her reports, indicating that curative treatment is no longer possible. So the focus is now on symptom management and quality of life. But at the same time, her family requests the doctors not to disclose the full diagnosis or prognosis to Ms. Mehra, and they fearing she will lose hope and give up. They also cite the cultural belief and the desire to protect her from the distress. So this is the scenario how a 58-year-old woman, those who are in life-limiting illness, how her family don't want to disclose the bad news with the patient. So what is our role? How we will effectively manage it? We will discuss at the end of the session. Before going to discuss about how we can effectively break the bad news, we have to understand what are the principles of communication. So I think you already know about what are the principles we should follow when we are communicate with the patient and their family members. So you can use chat box also, and you can unmute yourself and you can answer. What are the basic principles? Very good. Active listening, stanchion, empathy. Very good. Any other participants? Body language, yeah. Politeness, okay. Support, we can say the sympathy. Very good. Okay, great. So let's review the core principles of communication. As you mentioned that whenever we communicate with patients, we have to show the respect to the patient and family always. No matter what is the patient caste, what is the patient's economical status, what is the patient's situation now on patient family. Because sometimes we have seen that patient is on already on distress. His or her family already on distress. So respecting the patient and family will help us to gain the cooperation. And it will ease also to break the bad news with the patient and family when we respect. So always we have to treat the patient and family with uh, utmost respect. The second one is the empathy. So as you also mentioned about the empathy, when we understand the patient's feeling, so how in this situation, how patient is feeling, what may be the patient situation, what may be the patient family situation. So it helps us to acknowledge what what the things going on inside the patients. And if we will try to understand it effectively, it will help us to make a good relationship with the patients and their family. So at the same time, when we empathically deal with our patients, provide whatever we are going to provide, it may be more effective. Then come to the trust. Trust is one of the most important principle of communication. So through the empathy, we understand what patients in what suffering patient is going on, what are the patients feeling. So we always trust the patients and we always help the patient to understand what patient is going through and don't give pause like false hope. Most of the time what I have seen, the initially the palliative care practitioner with limited training, those who are dealing with the life limiting illness, I have encountered many times they give the false hope to the patient. So to maintain a good trust, don't give the false hope and don't lie in anything, because these things destroy the trust and it can break the communication, and it can affect the relationship with the patients and the healthcare providers. Then the unconditional positive regards. So we have always used non-judgmental approach because patient is in the serious situation or serious life limiting illness. So we have not to judge anyway. We have always uh, address the patient uh, positive regard and always talk with the family. If there any conflict between family, we have to address it and we try to resolve it. So always give a positive regard to the patient, respect it, and always use a non-judgmental approach. So these are the basic principle of communication. Uh, these principles will help us to break the bad news effectively. And we have also mentioned about the active listening. It's a very important aspect of communication because most of the time, uh, the healthcare professionals have limited time. My slides are visible. Okay. Most of we are giving family. So we are not they have lots of questions. They feel important. We listen the patient and family, whatever their doubt, whatever their questions, we have to address it. A breaking bad news is a stressful task for the healthcare professional, as one study shown that the physician breaking bad news, they shows the psychic and physiological stress reaction when they communicate the bad news with the patient and family. And stress is very common, and breaking bad news is distressing activity for both patients as well as the family members. So traditionally, the stress assessed self-reporting, and recently, in this physiological assessment was done. The Seven study used case scenarios with simulated patients, and it is reported that there is an increase in psychological and physical activation. So it is concluded that breaking bad news is not only cause stress, but also it leads to a psychophysiological arousal. How we can effectively communicate the disease condition or disease situation to the patient and their family. So what is breaking bad news? So according to Beckman's, breaking bad news is any information which adversely and seriously affect an individual's view of his or her future. So breaking bad news is something when the families think about that it can be affect to the patient's thinking, or it can be seriously affects and patient will lose the hope. So whenever we break the bad news, we have to communicate effectively with the family members. So maybe distressing. Bad news in healthcare, in terms of care, bad news is considered any information that change a patient's view of the future in negative way. So what family think that after sharing this diagnosis, like the patient, Mrs. Mehra, having ovarian cancer, if the physicians or the team will tell the Mrs. Mehra that you have ovarian cancer, she will lose the hope or she will be in distress. So breaking bad news is something that can change the patient view in future. Maybe willpower will be decreased. So generally, breaking bad news is a diagnosis shared with the patients. However, it can also include the communication of new chronic disease or information that a chronic disease has worsened. So as I mentioned that it impacts the individual to individually. Their consequence is distressing information on the patient and his or her family. So sometime the patient is affected with this breaking bad news because he or she may lose the hope, he or she may more distressful, and the patient's family also in the distress that they are going to lose the patients after disclosing the bad news. But ethically, it is very important as a healthcare professionals. So when we find out that uh, patients don't know about his or her status of the disease, we should discuss it with the patient's family and caregivers and disclose it with the help of multidisciplinary team. Now, the important thing is that for breaking the bad news, there is a standardized protocol. It is known as Spike 6-step protocol. So it is a evidence-based protocol, and it is very helpful how effectively we can break the bad news and what are the principles we should follow. So there are 6 steps in this. So in the step 1, we are setting the context, or we are planning how we can break the bad news. In the step 2, we are going to assess the patient perception. What patient is thinking about his or her condition. In the step 3, obtaining the patient invitation. So any type of questions that make uh, like look like an invitation. The patient want to know about the disease more, or more knowledge about the disease condition. Then the step 4, we have, based on patient's question, we have to give knowledge and information whatever we have. But at the same time, we have to keep in mind, don't give any false information, don't give any false hope. after the giving information, the step is addressing the emotion. So when we breaking bad news with the patient, sometimes patient feel helpless. Patient may be crying. So we have to address the emotions, and we have plan the strategies and summarize. So we'll discuss one by one how we can setting the context. So knowing about the patient diagnosis and beyond. So not only we have to know about the patient's name, what are the patient diagnosed. At the same time, we should know who are the members are in the patient family. As I mentioned that Mrs. Mehra family having two kids and the husband. So we should know about the family tree or genogram. So it will help us to identify who will be the decision maker on the behalf of Mrs. Mehra also, or who will be decision maker in the behalf of patient, and the relationship in between the patients and the family members. And what are the eco map or support system available? For example, the patient is only the family member. Patient is the only earning member of the family. And whenever patient know about this, patients having lots of worry, patient having lots of distress, patients having lots of insecurity. Who will take care of their child? Who will take care of their husband or wife, whatever? Who will take care? Who will pays all the unpaid EMIs? So lots of question come in mind with the patient when they got to know that they having this disease, life-limiting disease. Support system is very important. We should know, is there any infos, or is there any the system working in particular area, those who the children education, there any vocational services, is there any agency that support the family during this tough time? Ashi, can you mute yourself?
You can continue, sir.
At the same time when we are setting the understanding about the family genogram and support system, we need to understand about what are the clinical history of disease, because if we know the context easily, we can correlate now. What are the investigations result? Because these results will help us to ask or to give information or to ask patient or to get the invitation question from the patient. What may be plan for care? What may be a process? What is the next plan for the patient? So setting context, understanding about the patient, their family, diagnosis, the support system is very important. For patient perception. So after setting context, we should know how he or she know, how much he knows. So based on that, it will help us to initiate the question. So like what do you already know about your disease?
Sachin sir, you're on mute.
So in the patient perception, our main role is to uh, identify what patient is thinking about and what patient knows about his or her disease. Then obtaining patient invitation. So it is very important based on patient's what patient information we have, what patient's information have about his or her disease, what patient want to know. Like, would you like me to explain further about your disease? So we, at the same time, when patient asks this question, we have to note the patient expression. Whether patient uh, actually want to know about his or his. So what if patient doesn't know? Sometime due to any pressure or sometime family member want to know, but patient doesn't want to know. So we have to keep this invitation open for the future, and we have to follow the ethical rights here. We have to give autonomy to the patients. It means patient are right whether patient want to discuss or patient want to refuse now. So if the patient says, yeah, please tell me. So yes, I wish to know what it is. So you have to proceed with sharing the information. But again, always keep in mind, don't give false information. It is good if you have a multidisciplinary team whenever you are going to disclose the bad news, because there may be lots of questions, they may be related with the physicians. So it is good when the physician, nurses, and other members of the healthcare team will be available there. So proceed with sharing information. Whatever questions patient will ask, we have to share the information. Then knowledge giving information. How we can give the information. So just like it looks like wound have is not a simple one. Then take a pause, observe and wait for response for the patients. It's not simple, it mean I have cancer. Maybe patient will say you not a simple means does I have a cancer? So we have to support evidences, you have to support with the lab results. Thing is that breaking the bad news is not a task of the single nursing professional. It is a task of the whole team, and mainly the physician is breaking the bad news. So we may be a part of the team. So we say at the test results, so what is cancer? And take a pause, because the word cancer when patient will hurt, so patient have lots changes in their mind. So we have to pause it, be brief, we have to very sensitive, we have to avoid any of the medical terminology, and we have to be very point to point. Then when patient, we have disclosed this thing with the patients. So at the same time, we have to listen patient, we have to listen actively and always respond empathetically. We have to keep ourselves in the patient situation and we have to respond. We have to allow the patient if he or she want to be silenced or if he or she have any question. So don't give any false hope and false information. Always address the patient concern, like if patient is showing any anger, any, any distress situation. And always acknowledge the reaction, because this is very common. Sometimes when we know any of the bad, sometimes we feel also very angry. We feel in the state of denial. How it can be rejected? So think about that. Patients, those who having lots of dream, those who are having lots of wishes, patients having the family, they have lots of plan. Those who are incomplete now, if they know that they have a limited life left, what may be the reaction? So always respond empathetically and give option whenever you are addressing the patients. Try to help the patient to make a decision on the basis of available option. So always ask about the patient and their family whenever they feel asked what is possible, so what they have, what question they have in their mind. Okay. Then remain silent if we do not have an answer. Why did God do this for me? And lots of patients I have been many time patient and their family. They say that this happened to me. What sin I have did? What wrong I have did? So patients dual pain. So whenever these type of questions comes, always remain silent. Because this may be the first reaction. Why me? I have not did anything wrong in my life. I have did all my work very honestly. Why this happened to me? So we have to be very silent, and we have listen actively, and we have always respond empathetically. Then come to the strategy and summary. This is the last step of spike protocol. So ensure that whatever information is given, it should be understood by the family. So we have to again ask the patient have any like any doubt. So are there any point which you would like to make to explain again? So can you repeat what has been told? So we have to, for the confirmation, we can ask whatever I have explained you. If you have any doubt, you can tell me. And can you repeat what I have told you? So always jointly drawn a plan of care and support. So with the help of, because here patients also know about his or her condition. Patient family also know that the patient know what disease patient have, and the healthcare members also know that patient is already uh, the bad news is broken with the patient. So here, whatever care we will plan, we can include everyone in the plan of care. Always summarize the key points. What are the support system available? What may be the future plan? Is there any hospice or is there any palliative centers or home care services available if patient needs? And always record conversation details, because this will help the multidisciplinary team to follow clearly. So whatever conversation undergone, we have to record it and we have to keep it safe for the further follow-up. Sometimes patients having any type of financial issue, patient may have worry about the child education. So we have to find out the support system available in the community, society. So these things will ease, or these things will like support the patients and their family in this situation. Then the emotional response having the 5 stages, and it is a stage of grief. We have already undergo about this. The Elizabeth Kubler-Ross have given this stages of grief. So patient may be in denial stage. This cannot be true like that. This cannot be happening to me. So he or she will tell us. It may be, but once in a while, a patient may continue in denial. For some time, it is a good coping strategy, because for everything, whenever we first hear, we are denying. No, this cannot be happen to me. Why this to me? Why me? So, and after the some time, when patient understand and the family understand, they can accept it at the end. Then the second stage of grief is the anger. Anger may be get redirected in the form of shouting the messengers. Sometimes they shout to the doctor, in front of the doctor and nurses or the spouses and close family. I don't want to see anyone. I don't want to talk to anyone. Please leave me alone. So these type of phrases patient will say, and we confront these type of anger when patients know about his or her disease condition. Then the third stage is the bargaining. So bargaining may be with the God and may a company offers go straight hereafter. So in that situation, patient may ask some questions. Why this happened to me? Please forgive me. Please save me. Or please support me. Who will take care of my family? Lots of questions. Then in the fourth stage of grief, there may be depression. It is a normal to grieve and may need some help and support, because sometimes it go into the clinical depression. So we have to identify early it, and if there is, we need to treat it. And at the last, there is acceptance. So in this state, well, this has happened to me and I can't undo it. Let us see what we can do about it, and uh, how we can make it will not affect further, and uh, how we can live with this. Okay, because here patient accept that he or she may having the life limiting illness, and as there is no how we can proceed it with this. So these may be the changes in emotions when we break the bad news with the patients and their family. Till now, if you have any questions, you can put in the chat box. Participants, is there any questions? Okay. Then, what are the nurses' role? So, in the Indian scenarios, we have experiences. Most of the patients, sometime we have our own life experiences, but sometimes we have very limited experiences in dealing with the palliative care or the patient, those who are having life-limiting illnesses. So, at most of the time, and the physician is the only authorized to make the difficult communication and prognostication on breaking the bad news. And sometimes we have a team of the healthcare providers or multidisciplinary team available there. By default, an unprepared nurse is the thrust into the distress situation. So think about that. If you are the healthcare professional, you are the nurse, and there is a need to break the bad news and you are unprepared, so don't do it, because it may cause unnecessary distress situation to the patient and family. Sometime without a team, it is difficult to answer all the questions, patient question, and these unanswered question may be distressful to the patient and their families. And at the same time, nurses bear the brunt of not knowing how to handle self patients or caregivers. So if we'll try to break the bad news without our team, so sometimes it is difficult to handle that situation. So to prevent these type of chaos or stress or burnout, we have to address it with the team. So how we can improve it? Practice, always practice, practice, practice. Simulate it, make a case discussion, get some trainings, involve the interdisciplinary team, and work with the team. So all these things ultimately improve our skills, how we can be a part of breaking the bad news. And if any questions come in mind in between, how we can deal it. Then this is about the breaking the bad news. Then come to the collusion. So this is the term comes from the Latin origin colluder, which means to play together. So collusion is defined simply as a conscious phenomena suggesting a deliberate choice or even an act of love of the colluder. So this phenomena occurs across the culture frequently in the palliative care setting following prognostication. So when we are prognosticating someone, we are using this phenomena as it serves to avoid unpleasant and painful feelings. When we are avoiding sharing the bad news with the patients or with the family, patient don't want that bad news to be shared with the family, so it is known as collusion. Strategies to support patient and family during the collusion. So always check for the primary concern. What are the primary concern? Like whenever patients know about he or she is having the life limiting disease, so as we can see in case of Mrs. Mehra. So Mrs. Mehra think about that who will take care of her child. Okay, so always check for the primary concern. What are the first things come in mind of the patient whenever we break the bad news, when there is a collusion, when we share the bad news with the patients and the family, and always acknowledge the primary concern. And think about what are the benefits of truth telling. Okay. So if we will not disclose it with the patients, it may be an ethical issue, it may be a uh, ethical situation, unethical situations. So at the same time, when we are going to break the bad news and tell to the patient, what are the benefits of telling the truth? Okay. Because sometimes what happen, we are providing care, we are planning for care of the patients. What are the individualized care we can plan? But patient don't know how it can be planned, and we are not able to understand the wishes of the patient. We are not able to incorporate it. So we have to think about whether if we will tell the truth, whether it will be benefited or is there any harmful effect of collusion. As most of the family think that whenever bad news is broke with the patients, it may be patient may be lose the hope, patient may be in distressing situation. So always see the risk and benefit. Then challenges in the non-offensive manner. So it should be what whenever you break the bad news, it should be in a polite way, and from the patient side and the family side also, no any offensive like action would be taken. So we have to always think about the patient situation also. Whenever we break the bad news, what challenges come inside? Reassure the confidentiality, honor, and patient wishes for the non-disclosure. So most of the time, patients and their family don't want to disclose it with the anyone, or patient don't want to disclose with the family, and patient family don't want to disclose it with the patient. So confidentiality is very important principles of ethical principle. And but at the same time, we have to think about the patient wishes. If patients have wish to know and patients want to know, we have to discuss it with the family and disclose it. So these are the strategy to support. We have to always use a non-offensive approach, always maintain the confidentiality. Whenever we are planning, see the truth and harmful effect. What may be the beneficence, what may be the it may be non-maleficence. We have to acknowledge it, and we have to check with the what may be the primary concern when we break the bad news. What are the emotional and psychological problem with prognostic disclosure and risk of collusion? So it will prevent patient from psychological adaptation and coping, dissatisfaction with treatment, which determine overall quality and sense of well-being. It will also risk how team deliver the prognostic disclosure can impact patient and family positively or negatively. And it recommends separate assessment of disclosure wishes for patient and caregiver. So when honest and complete disclosure is not revealed, it may provoke strong emotions, unreflected behavior, and negatively impacted care. And it can cause patients high level of anxiety and depression. So we always think that if we will not disclose it, how it can lead to risk the patient emotionally and psychologically. Sometimes the depression can lead to the clinical depression. So always think about whenever we break the bad news or disclose the bad news, how it impact the patients. Prognostic disclosure and collusions. What are the advantages? As evidence shows that an average 23 to 30 minutes to an hour time spent on the prognostication can improve the significantly outcome of care, and lack of it can cause mistrust and invariably therapeutic irrevocably therapeutic relationship. So thing is that if we will the breaking the bad news without the spike protocol, without our team in a minutes, it may be a distressing. It may be it can cause the lack of mistrust, and it can be distressing to the patient and family. It can lead to the depression also. But if we will do it with the spike protocol and with the proper proper setting the context and understanding about the patient situation, it may be effectively, and it can improve the outcome of the care, because we are going to involve the patient in the care plan. So the care should be a patient centered. Often it is found in non-disclosure patient are aware about their diagnosis and prognosis to a certain extent. Most of the time the family think that, the healthcare professional think that the patient don't know about his or her disease situation, but in some extent they know. So it's better to disclose the bad news, and with the help of our multidisciplinary team, and it will help us to improve the outcome and better care. So what may be the nurse's role in the palliative care when we break the bad news? So there should be a proper awareness, the complexity of communication that can help the families cope with the distress situations or difficult situation on taking the decision. In palliative care, breaking bad news is often associated with the discussion of disease progression, time of survival, and situations such as actively dying or opposed to the news of an initial diagnosis or prognosis. A trusting relationship is extremely important. So whenever we are discussing, whenever we are disclosing anything with the patients and family, before that we have to maintain a trustful relationship. Discussion concerning ending curating treatment and reestablishing plan for palliative care treatment are part of nurses' role. So always take a charge and discuss with the treating physicians about what may be the possible, what may be the next plan for the patients, and always advocate for the patients. So breaking bad news discussions may have to occur frequently in an effort to help patient and family members understand the aspect of palliative care. So the nurses should be always uh, take a front and to be a part of the multidisciplinary team. Whenever the bad news is break with the patient, they always with the patients to support and to address the support system available and to address the emotional emotional situation patient undergo. Emotional care and support of the family require not only the initial bad news discussion on ending life sustaining treatment, but also continued preparation for reiterating what to be expect as the patient enter an actively dying phase. So we have to think about when patient may be in end of life phase, what are the preparation, what are the patient's last wishes, what are the patient's incomplete task patients left, what are the patient's unfulfilled dreams. So we have to always address the patient wishes. So breaking bad news is generally not an one-time event, and nurses must work with the families to process the difficult information and provide clarification as needed. Sometimes patient is not able to tell you everything in a single sitting. You have to make a trust, you have to build a relation, then only patient will share you everything about the last wishes, about the uh, unfulfilled dreamed, unfulfilled wishes. So full disclosure of life expectancy at the end of life increased, creating a need for more breaking bad news encounters. Communication must be uninterrupted and delivered with mindfulness to allow the listener to the process of end of life and eventual death of loved ones. So there should be a flow of communication. There should be a principle of communication incorporated whenever we are dealing with the life limiting illnesses, whenever we are dealing with the breaking bad news with the patient and family. Thank you. So let's come to the case scenarios we have discussed. As Mrs. Mehra, a 58-year-old woman, has recently diagnosed with advanced ovarian cancer. She is admitted to the palliative care unit with the progressive symptom, as her husband and two adult children are her primary caregivers. In the situation, the medical team reviews her reports indicating that the curative treatment is no longer possible. So the focus is now on symptom management and improving the quality of life. But her family requests the doctor not to disclose the full diagnosis or prognosis to Mrs. Mehra because they are fearing that she will lose the hope and give up. They also cite the cultural belief and their desire to protect her from the distress. So how we can handle this situation? What are the principles we can use, and what nurses can how nurses can effectively help the multidisciplinary team to break the bad news here? So you can use chat box to answer the question. You can use the chat box. Participants, please respond. You can use the chat box or you can unmute yourself and also you can tell.
Sachin sir, or else you can call someone's name or you can ask some questions.
Okay, okay.
Otherwise, they won't respond. That's
Repeat the questions, sir. They're
Okay.
asking.
Okay, so you have seen the scenario that the Mrs. Mehra, those who are having ovarian cancer, but uh, her family don't want to disclose the bad news with the patients. Okay, what are the principles of communication and what are the nurses' role here, how effectively we can communicate this bad news to the patients, and how we can convince the family. What are the principles of communication we can use here? And what situation is this? Very good. Provide psychological support to whom? To patient or to family? Yes, to both patient and family. What is the situation now? Her family request the doctor not to disclose the full diagnosis. What is the situation now? So empathy. Yes, Sarita rightly said we have to say empathy. So in this scenario, there is a collusion. So how we effectively we can manage the collusion? Yes, to maintain a trustful relation. Okay. We can encourage the patient and their family, encourage the family to disclose this bad news with the patient. Okay. Okay. Thank you. So there is a communication dilemma here. As Mrs. Mehra directly asked the physician, Doctor, I know something is wrong. Please tell me truth. I'm going to get better. The physician faced collusion, balancing the respect for the family's wishes with the ethical obligation to inform the patient. In this situation, it requires a careful, structured approach using a protocol like spikes, seeking patient invitation, providing fact honestly, exploring emotions, and supporting both Mrs. Mehra and her family. Approach and outcome, the team arrange a private conversation, gently ask Mrs. Mehra how much she wishes to know and assess her perception of her illness. Gradually, the physician shared that the disease is serious and treatment is aimed at comfort, not cure. Mrs. Mehra expresses sadness but relief in knowing the truth and asks for her family to be involved in planning her care. The family, while initially distressed, is supported to understand the importance of honest communication, and together they make decision for Mrs. Mehra ongoing care. So, how this spike protocol changed the scenario, how they have planned the conversation, and now the physicians share the uh, bad news with the patient, and as Mrs. Mehra expresses, initially the sadness may be in the phase of denial, but at the end she accepts the truth and asks for her family to be involved in planning of care. So it's a good thing that she she want to be a involved family members in the care, and she feel more supported. Family was also initially distressed, but when they supported, when they involved in the care, they feel that the patients is now know the status and it will ultimately improve the outcome of the patient. So uh, how here we can see that how the honest communication, how the sympathy, how empathy will play a big role, and how effectively we can break the bad news, and how much is important in this case of Mrs. Mehra, because if their family don't want to disclose it with the Mrs. Mehra, so it may be one of the unethically ethical dilemma situation. So we have to manage this type of dilemma very carefully, using the communication principles and addressing the issues. Thank you. So if you have any question, you can ask. I have stopped the share. Participants, if you have any question, you can use the chat box or you can directly unmute yourself and ask also.
Dear participants, kindly ask your doubts. Sir is with us. Or else you can share the feedback. How was the session? And Kanagaraj?
And if you have any personal experience you want to share with us, if you are a part of the team, those who bad news, if you have seen someone, those who are having life-limiting illness, but he or she don't know about his or condition.
Session is excellent. They don't have any doubts, I think. Helpful session. Thank you so much, sir. It's a wonderful session. It's very good, actually.
Thank you, ma'am. Thank you all.
Thank you, sir.
Helpful session.
Helpful session, and please share the PPT with me, then I can share on the platform. So, can we wrap it up for today's?
Yeah, thank you. I will share it with you.
Yeah, sure, sir. Thank you, sir. So, dear participants, you can leave now. We can wrap it up for today. See you all in the next session.
Thank you, everyone. Thank you.